Good morning all. My name is Dr. PG Madam Rafi. Today we are going to discuss about anticoagulants. So in anticoagulants we have two types, natural anticoagulants and synthetic anticoagulants. Okay. In natural means these are naturally provided by the body. So these are having anticoagulations. That means when normal blood circulation happening in the blood vessels, the blood will not be get clotted because of this natural anticoagulants. What are those natural anticoagulants we have? Those are prostacyclins, antithrombin 3, protein C, and heparin sulfate. This prostacyclin will block thromboxane A2, thereby it will inhibit clotting in the blood vessels. Samely, antithrombin 3 will act on different clotting factors. Those are 2, 9, 10, 11, 12. By inhibiting these factors, they will inhibit coagulation. Next is protein C. It will inhibit clotting factors like factor 5 and factor 8. Samely, heparin sulfate, it will act by different mechanism. It will enhance activity of antithrombin 3. Thereby, it will inhibit these clotting factors. Thereby, it will show anticoagulation property. Okay. These are the naturally provided by the body and they will act as anticoagulants. We will see next following slides. Those are synthetic anticoagulants. These are synthetic. So they have two forms, parental form, oral form. Parental anticoagulants will have heparin, low molecular heparin, synthetic heparin derivatives, direct thrombin inhibitors, pyridine based synthetic thrombin inhibitors. Okay. So first of all, heparin. Heparin mainly enhance activity of antithrombin 3. Thereby antithrombin 3 clotting factors will get blocked. So obviously they will be anticoagulation property will be generated. Samely, next they develop low molecular weight heparin. They also enhance antithrombin 3 activity. In this group we will have drugs like enoxaparin, dalteparin, riviparin. Okay. Here every group we should remember the names because they will ask mostly the names and they will ask the clotting factor whether it will enhancing activity or whether it may be blocking the activity. So here heparin will enhance activity of antithrombin 3. Heparin also enhance activity of antithrombin 3. Here the group of drugs will be enoxaparin, dalteparin. Next synthetic group will be also antithrombin 3. The synthetic group will have drugs like fondaparinux sodium, idraparinux sodium. Okay. Next group is direct thrombin inhibitors. These direct thrombin inhibitors will prevent factor 13, that is clotting factor 13. It will be beneficial and it will be useful in fibrin deposits. Okay. So therefore, when the fibrin will not be get deposit, obviously there will be no clotting will happen. Thereby it will show anticoagulation property. Okay. So in this the direct thrombin inhibitors group will have pyridine base, that is lipirudin, bivalirudin. Here we should remember the names. They will ask mainly the names only and the clotting factor. They will the action on the clotting factor. Next is synthetic thrombin inhibitor, that is argatobran. Next recently developed molecule is doticogin alpha. These are parental form. Okay. In oral form we will have direct thrombin inhibitors like dabigatran, direct factor 10A inhibitors. This is mostly repeated only, but we should remember easily by this is 10A, right? In the name also 10A will be there, that is apixaban, rivaroxaban. So if we see this one, this XA, that is XA will be there. So direct factor inhibitor 10A inhibitors will be apixaban and rivaroxaban. Next oral anticoagulants will be vitamin K antagonists. Those are warfarin, very important drug, and dicumarol, phenindione. Okay. So these are the parental and oral. We will discuss each one in the following slides. In this slide you have to remember the name and the action on the factor. Okay. So next we will see heparin. Heparin mainly it is extracted from the liver. The molecular weight of heparin is the range is 10,000 to 40,000 daltons. It is mainly located in the mainly synthesized in lung, liver, and intestinal mucosa. It is released along with histamine into the circulation. The main mechanism of action of heparin is they enhance antithrombin 3, thereby it will inhibit the clotting factors 2, 9, 10, 11, and 12. Mainly the 2 and 10 clotting factors. Thereby, obviously, by inhibiting these clotting factors, they will show the action of anticoagulation. anticoagulant. Okay. So at higher doses they inhibit platelet aggregation and rise APTT levels also. Okay. So next group is low molecular weight heparin. They also show activity by enhancing activity of antithrombin 3 complex, but clotting factor mainly on factor 10. Heparin is factor 2 and 10. Low molecular weight heparin, it will show mostly on factor 10 only. Okay. So it can be given subcutaneously. Compared to heparin, it has more bioavailability and better bioavailability. It doesn't prolong APTT, that is active prothrombin thromboplastin time. Okay. Heparin will prolong APTT levels. The main antagonist for low molecular weight heparin is protamine sulfate. This is an MCQ. Okay. You should remember this is most commonly asked only, but then they will not repeat. But you should know the antagonist of low molecular weight heparin is protamine sulfate. Okay. Here the main thing is heparin acts through which factors? Antithrombin 3. It is enhanced activity of antithrombin 3. Thereby which clotting factors? 2, 9, 10, 11 and 12. Mainly 2 and 10. Low molecular weight heparin mainly acting on the same 83 complex, but mainly through factor 10. Okay, it is 2 and 10. Low molecular weight is factor 10 only. Okay. Next in this group very important is direct thrombin inhibitors. In this group the drugs will have lepirudin, bivalirudin, argatroban. Before going to discussion about these drugs, we need to know about the thrombin actions. So this thrombin action normally it cleaves fibrinogen to fibrin and activates factor 13, which makes fibrin to stable clot and activates platelets. All these three leads to form thrombus. So by inhibiting thrombin, we will may get activity of anticoagulation. So in this group, we will have drugs like lepirudin, bivalirudin, argatroban. These group drugs will now called as hirudin-based thrombin inhibitors. Okay, why hirudin-based means? First of all, this hirudin it is mainly obtained from salivary gland of leech. It will be act as a irreversible inhibitor of thrombin. This is an MCQ. Hirudin is obtained from salivary gland of leech, so it will have irreversible inhibitor of thrombin. It is naturally obtaining. Later on, they develop lepirudin, bivalirudin. Okay, these are recombinantly developed molecules. Lepirudin is obtained from yeast cells, so it will be mainly useful in heparin-induced thrombocytopenia, most commonly and most repeated MCQ. Heparin-induced thrombocytopenia will be treated by lepirudin. Okay, it is group belongs to hirudin group. Okay. Next is bivalirudin. This is mainly useful for angioplasty. That will be same the hirudin group only. In this thing, these are all naturally. Next is in this group hirudin base will have synthetic molecule, that is argatroban. This is synthetic non-peptide molecule. It is not natural one. Okay, synthetic non-peptide inhibits also thrombin, mainly useful for this coronary angioplasty and heparin-induced thrombocytopenia. Argatroban is also useful for heparin-induced thrombocytopenia, that is it. Lepirudin is also useful for HIT. Okay, if they ask lepirudin and argatroban, we can go with lepirudin. Okay. Next last in this group is vitamin K antagonist drugs. Vitamin K antagonist drugs we have warfarin, dicumoral, phenandione. Okay. In these three, warfarin is main important. Obviously, warfarin is inhibit vitamin D dependent clotting factors. Those are 2, 7, 9, 10 clotting factors. Mostly vitamin, that is clotting factor 2. So when patient is on warfarin, we should monitor prothrombin time and INR, international normalized ratio. The warfarin will have more bioavailability, that is 100%. In this 99% will be plasma protein bound, 1% will be freely available. So that's why when drug is having interaction with warfarin, if 1% is also availability increases, they will have chance of developing toxicity. Okay, that's why it will have more drug-drug interaction. So we should be very cautious when patient is on warfarin. Because of these high bioavailability, they have low volume of distribution, because it will be 99% will be completely bound to the protein. So the other tissues they will have very less, right? So obviously low volume of distribution. This warfarin is metabolized by cytochrome 2C9 and excreted through urine. So when patient is developed warfarin toxicity, the antidote should be obviously vitamin K and fresh frozen plasma, because of we need to replace the clotting factors because they inhibit all these clotting factors. Okay, that's all.